Hello, my name is Alexandra, and thank you for joining us for the latest edition of the Compass Health Activation webinar series. Today's webinar is entitled The Top 10 Sources of Healthcare Utilization. Our presenter today is Compass co-founder and Chief Medical Officer, Dr. Eric Bricker, and I will turn the floor over to you, Dr. Bricker.
Great. Thank you so much, Alex, and thank all of you for joining for the Compass webinar today, the top 10 sources of healthcare overutilization. And as many of you are already aware from being on previous Compass webinars, just a short background about myself. So I'm a general internist. I did my training at Johns Hopkins in Baltimore. But before I went into medicine, I actually used to be a hospital finance consultant, so dealing with all the bills and medical contracting issues on the doc and the hospital side before being more clinical and going on to medical school and residency. And so really wanted to take what I had learned on the finance side and kind of marry that with the bedside and patient care, and really just found a lot of confusion and frustration on the part of my patients, really regarding all of those administrative aspects of getting healthcare services. And so that's why myself and my co-founders wanted to start Compass Professional Health Services. Just a short background about myself, many of you on the call are existing clients, insurance brokers, benefit consultants, and some prospective folks as well. I also write a blog on a daily basis that we're fortunate I was honorable mention again in 2015 by Reagan's, which is a big PR firm that ranks blogs every year, so super fortunate for that. And then also we have the LinkedIn Healthcare Price Transparency Group, where if you subscribe, you get the blog sent to you daily. We have over 2,000 people subscribed to that now, so just so fortunate to be able to share some healthcare industry knowledge with all of you. So in Compass Professional Health Services, we're tools and support for healthcare consumers. We have a healthcare activation platform where we provide in-network price transparency through our Health Pro concierge and technology service to go along with an employer's health plan. We also steer people into their primary care physicians so they can get their necessary preventive care. And then we also steer them through our Pathways program to high-quality, cost-effective physicians for subspecialty care or tests or imaging or procedures, and that then feeds into needing to use the concierge service some more. And then you can see that it's essentially a virtuous loop of health activation that Compass is able to provide for employees at our clients. And so we have over 2,000 clients, from T-Mobile to TXU and Encore, which is Energy Future Holdings, Nebraska Furniture Mart, which is a Berkshire Hathaway company, education like Southern Methodist University, manufacturing like Overhead Door and Barry Waymiller, retail like Dillard's and Michaels, airlines like Southwest. They're just so fortunate to be able to have so many wonderful clients that we work with. We've also just recently added a $4 billion publicly traded trucking and logistics firm, and we've also added one of the sort of family office of, frankly, one of the world's most prominent families for their North American employees, along with a commercial real estate firm that's also one of the largest commercial real estate firms in the country. So just wonderful clients and new clients that we've added, and again, so fortunate to be able to work with all of you. So now let's turn to the topic for today, the top 10 sources of overutilization. So number one is antibiotics. And so this is a good one to start off with just because it's so common, right? Antibiotics are prescribed, it says here, overprescription of antibiotics is oftentimes for upper respiratory tract infections. So oftentimes it's for people when they have, sinus congestion or sinusitis, bronchitis, which is sort of a hacking cough, or a sore throat. And in fact, antibiotics are actually prescribed 73% of the time for bronchitis. And in fact, bronchitis is almost never caused by a bacteria. It's almost always caused by a virus. So obviously, antibiotics aren't going to help treat a virus at all. But, the common thing that people say is, yeah, but when I took the antibiotics, I started to feel better. And so I'm just going to briefly tell you how your immune system works when it comes to a viral infection like bronchitis. And so essentially, when the virus first enters your body, you don't even realize it, and it needs to replicate and expand to literally hundreds of millions of copies before you start having the symptoms of the congestion and the cough. And as it expands, then your immune system starts to kick in. And it takes actually 3 to 5 days for what are called the T cells in your lymph nodes to correctly identify which virus it is, and then they go through a process called T cell clonal expansion, where the T cells specific to that virus just massively grow and then attack that virus. And that whole process takes about 3 to 5 days. So what happens during those 3 to 5 days? You're not feeling so well, you're tired, you're run down, you finally say, well, look, I've had enough, I'm going to go to the doctor and I'm going to get some antibiotics. So sure enough, you get put on antibiotics and you start taking them on day like 5 and 6. And what happens on day 5 and 6? Well, that's when your immune system starts really kicking in. So here you are taking the antibiotics thinking that it's making you feel better, when in fact it's that T cell clonal expansion that has caused the rapid improvement in your symptoms. I will tell you personally, I have not taken antibiotics for a cough or upper respiratory tract infection, I think in like 20 years, if not more than that. So that's just one example, not to overemphasize it. But then number 2, antibiotics are prescribed 60% of the time for sore throats, or only 10% of the time is it actually bacterial. That's for strep throat, right? So other than strep throat, there really is not a reason for antibiotics in the case of a sore throat. Common antibiotics for upper respiratory tract infections are azithromycin, amoxicillin, Augmentin, and Levaquin. And so obviously the needless expense aside, it's important to have caution when taking antibiotics unnecessarily, because when you take antibiotics, it also not only kills bacteria where you might have an infection, but it also kills the good bacteria that is in your colon, right? I'm sure all of you have heard that you actually need good bacteria in your colon. And so when you take azithromycin, amoxicillin, Augmentin, and especially the Augmentin and the Levaquin, so these really strong, powerful antibiotics, they greatly diminish the good bacteria in your colon. And what happens is that there's a bad bacteria called Clostridium difficile, or C. diff for short, that then can take advantage of that decreased bacteria in the colon and can rapidly grow and expand, and in some cases it can become incredibly severe diarrhea and colitis and colon inflammation to the point where a person's colon might even need to be surgically removed. So that's very rare that that happens, but at the same time, it's very rare to get struck by lightning, and you still don't want to stand outside in a thunderstorm, right? So just because it's rare doesn't mean you don't want to be careful about it, because it does have such serious consequences. And in fact, on the Medicare Hospital Compare site, it actually uses C. difficile hospital infections as a measurement of quality. And so one of the best things that you can do as an individual is just to make sure that you're only taking antibiotics when you have a bacterial infection and when you really need it, and not for something that's more likely to be viral. So number 1 source of healthcare overutilization is overuse of antibiotics. Number 2 is imaging. So people in America have far too many MRIs and CT scans. One of the most common reasons for an MRI is for low back pain, where they actually have done numerous studies that have sort of been summarized in what are called the Choosing Wisely guidelines by the American Board of Internal Medicine and the American Academy of Family Practice, and they found that for people that had low back pain who had an MRI, that their symptoms and their outcomes were actually the same as those that didn't have an MRI, but just more conservatively treated their back pain, such as with heat, pain relief, just whether it be over-the-counter Tylenol or ibuprofen or Motrin, and just with physical activity. Actually, bed rest is actually not what you want at all for low back pain. It's actually recommended that you should have no more than a day or two of decreased activity, and that maintaining activity is very important for your recovery. Now, there are certain red flag symptoms where if you have, whether it's weakness or numbness in your legs, then absolutely you need to have an MRI done. But in the absence of those red flag symptoms, there's really no point in having that MRI done. And they also found that if you did have an MRI, that you were 8 times more likely to have surgery than if you didn't have an MRI. In other words, if you start going down that rabbit hole, then it is more likely to lead to surgery by 800%. And you end up having no better outcome. So you want to make sure that you don't go down that slippery slope, which In the case of headaches, 90% of headaches are, again, migraines that don't require an MRI or a CT scan to diagnose. So again, that's where actually going into the physician and having them do a physical exam and take a history, and oftentimes the migraine can be diagnosed based upon the history and the physical, and an additional MRI or CT is not needed to actually evaluate. Now again, if they're red flag symptoms such as, blurry vision or what have you, weakness or numbness in a certain arm or leg, then certainly getting an MRI or CT scan in that situation might be appropriate. But I think the take-home message with imaging here is just to ask if there are other options if the physician is recommending an MRI or a CT scan, just to make them pause and think for a minute, do I really need this scan? Because you as a patient are asking them, look, do I really need this? And that you might still need the scan, but in a lot of cases you probably won't. Okay, overutilization number 3 is spine surgery. So most often spine surgery is done for low back pain. It's referred to oftentimes as a laminectomy, which actually means removing part of the vertebral bones in the back, or it might be referred to as a discectomy as well, actually removing a disc, and then they actually might fuse some of the vertebrae as well. And when they've done actually quite a few studies evaluating surgery versus non-surgery for spine, and the British Medical Journal, this source here at the bottom, the British Medical Journal is essentially the JAMA of Great Britain. They did a meta-analysis where they looked at all of the studies evaluating surgery for low back pain. And essentially, the outcomes are mixed. The findings are mixed. That in some studies, the surgery was better. In other situations, physical therapy plus pain relief, actually plus counseling, was actually more helpful than surgery. And the reason for the counseling is because there's unfortunately a negative feedback loop between pain and depression. And obviously, if you don't feel well, it can just take over your life, and it can make you feel depressed. And to pull yourself out of that depression, you need to treat the pain, but then you also need to treat the depression through, whether it's through counseling or through antidepressants as well. So that sort of dual approach to pain therapy involving mental health as well is super important for improvement. And so in that case, that sort of mix of therapies instead of surgery, sometimes has been found to be superior. Also, USA Today had a very popular publication back in June of 2013 that found that 17% of patients who were told they needed surgery actually had no history, physical exam, or imaging findings that indicated they truly needed surgery. So 17%, that's 1 in 6. So if you are recommended for surgery, there's a 1 in 6 chance that there's actually no indication for it whatsoever. And so really the takeaway for spine surgery is that if you are evaluated by a surgeon, and it's typically either an orthopedist or a neurosurgeon specializing in spine, I would tell this to my own family members, you'd probably want to get a second or maybe even a third opinion before you decide what to do, because the decision of whether to or to not have surgery might be fairly subjective. And you might have very objective reasons for needing that spine surgery, in which case you're probably going to have all 2 or 3 of the physicians agree. But if it's more of a subjective scenario, then you're going to want to weigh alternative options as well. Okay, so number 4, knee joint surgery. So this is oftentimes arthroscopic surgery on the knee done for knee pain, but one of the most common causes for knee pain is what's referred to as just osteoarthritis, which is a fancy medical term for just wear and tear on the knee, frankly just because of advancing age, or a lot of times it's compounded by being overweight. So the knees and the hips are considered the weight-bearing joints as opposed to the shoulder, which really doesn't bear much weight. And so with time and with excess weight, there's really a lot of wear and tear on those knees. So there are over 700,000 arthroscopic knee surgeries performed every year, which total cost of $4 billion. They actually did a remarkable study where they wanted to see if arthroscopic knee surgery actually helped in cases of osteoarthritis or wear and tear of the knee. So they had 2 groups. It was a randomized study, so you either picked to be in Group A or Group B, and in Group A, they actually did real arthroscopic knee surgery on the patients. And in group B, they did a complete sham surgical procedure. And by sham, I mean they dressed them in a gown. They put them on a gurney. They wheeled them into the operating room. They put them under anesthesia. They even cut the skin so that they would have the scars, and they had to sew the skin back up. But they didn't do anything past cutting the skin. They didn't actually operate on the knee joint itself. And it was so remarkable because both groups were equally as satisfied. So the people that had the complete sham surgery had the exact same satisfaction in their symptoms after the surgery as the people that actually had real surgery. And so there is a real possibility that if you have osteoarthritis of the knee, that actually surgery is not going to help you at all. And so surgery may still be helpful for those with knee surgery without osteoarthritis. In other words, for people that have acute injuries, so this would be like your classic like ACL tear from playing sports or going water skiing, or for like a meniscal tear, again, typically from an injury or an accident. But again, that's not wear and tear, that's an acute injury. But those acute injuries are only really 20% of knee pain. And so again, I would say here too, listen, the knee surgery for your particular situation might make sense, but again, if it were my own family members, I would say to them, look, probably should get a second or maybe even a third opinion before having this type of invasive surgery on you. So, overutilization number 5 are GI endoscopies. Okay, and so an endoscopy is performed by a gastroenterologist usually, so that's a stomach and digestive system physician. And an upper GI endoscopy is where they take an endoscope, so it's a fiber optic scope where they can look at a camera inside of your esophagus and your stomach, and then there's also additional holes that they can put instruments down through so that if they need to take a biopsy or if they need to inject a medication directly into the lining of the stomach or the esophagus, that they can do that. So the official term for an upper GI endoscopy is abbreviated in EGD, but I now want to teach you probably the longest word you're ever going to know. The official name of an EGD is an esophagogastroduodenoscopy. And so if you break that down, esophago refers to the esophagus, gastro refers to the stomach, duodenum, the duodenum is the first part of the small intestine. It's about the first 8 inches of the small intestine. So you can actually visualize the first part of the small intestine, but the full 12 to 14 feet of the small intestine you cannot visualize because it has 2 serpentine or circuitous of a path. So you can only look at really the first sort of 8 inches of it. But that's an EGD, right? So if you need a scope, or they call it an EGD, you'll know what that means and what that refers to. But there's a really great CBS News article in December of 2012 that showed that the inappropriate use of upper GI endoscopy does not improve the health of patients, and this is specifically in regards to heartburn. So it exposes them to preventable harms, may lead to additional unnecessary intervention, and results in unnecessary costs and no benefit. In other words, one of the most common reasons for getting an upper GI endoscopy is for people with heartburn. I mean, it's estimated that 1/3 of U.S. adults experience heartburn at least on a weekly basis. And so it is, if you go into a gastroenterologist with heartburn, I'm not going to say all the time, but the vast majority of the time, you'll likely end up getting an EGD. Then to the next quote, that first recommendation to patients to try to make lifestyle changes to reduce their GERD, and GERD is gastroesophageal reflux disease, or another fancy word for heartburn, and to try to get off medications if possible. So in other words, when you go in and do that endoscopy for heartburn, you're going to see evidence of the esophagus being burned, but it's not going to change what your treatment plan is at all. You're going to tell people to change their lifestyle habits so as to have less heartburn, and then you might prescribe an antacid medication like Zantac or Pepcid or Prilosec or Nexium. And so the point is that you can do a trial of those antacid medications and lifestyle change before you even have the scope, because it's not going to make a difference. And so really, the take-home message here is to consider just going to see a PCP first, because the primary care physician is not going to perform the endoscopy, and they might say, well, look, you have heartburn, let's just try it out on the antacids first and see if you get better. And if so, great, you've avoided the scope. But if you have, again, persistent heartburn, or you have some what are called red flag symptoms, again, of let's say trouble swallowing, like if you swallow and you feel like food actually is getting stuck in your esophagus and not going into your stomach, well, then that might be a red flag symptom to actually have the EGD performed. But most people with heartburn don't feel like things are getting stuck. So the only thing I would add to this slide is that really the lifestyle modifications for GERD or reflux or heartburn are very important. So you want to take the medication, but the three most common causes of reflux and heartburn are unfortunately the three most common vices in America, and they are alcohol, caffeine, and tobacco. So, and the reason for that is because all three of those actually cause the one-way valve between your esophagus and your stomach, which is called your lower esophageal sphincter, right? So if you were to drink water and then hang upside down, the water wouldn't come out of your stomach, right? And the reason for that is because the lower esophageal sphincter lets the water come through but doesn't let it come back out. Well, coffee, alcohol, and nicotine actually cause that lower esophageal sphincter to open and then not close all the way. And so, it's, now that's hard to do. It's super hard for people to stop doing any one of those three things, let alone all three of those. I mean, are there people that smoke and drink coffee? Absolutely. And it's almost guaranteed that those people are going to have heartburn. So, so just know that when you see the PCP, taking the antacid medication is important, but then the lifestyle modification is important as well. Okay. Overutilization source number 6 are heart stress tests. Okay, so these are cardiac stress tests often done for people to see if they have what's called ischemic heart disease, or to see if they actually have blockages in the vessels of their heart that might be causing some type of heart-related symptoms. It could be chest pain, it could be shortness of breath, it could be the feeling of palpitations or fluttering in the chest. And the Veterans Administration actually found that within their VA population, that stress tests were ordered 10 to 15% of the time, and that other studies have shown that it might be as many as 44% of stress tests are inappropriately ordered. And the cost of that stress test is about $3,500 to $6,000 per test. Now, why is it that they're so frequently inappropriately ordered? Because oftentimes, one, people will say, oh, well, I'm getting to middle age, and I have a family member that had a heart attack, so I just want to get, quote-unquote, screened to make sure I don't have heart disease. Well, stress tests are not appropriate in asymptomatic people to screen for heart disease. That is, the American College of Cardiology has come out and recommended against that. If you're not having symptoms, you should not just get a stress test because you have a family member that had a heart attack. I mean, heart disease is one of the most common causes of ailment and death in America, so you probably don't have a quote-unquote family history of heart disease. It's probably just because your relative got old and had cholesterol in their arteries. So if the other reason that a lot of people get stress tests is because there's other things in your chest that can cause pain besides your heart, right? What else is in your chest? Well, your lungs are in your chest, your esophagus is in your chest, and you have your rib cage and then the muscles between the ribs that also are there as well. And so your esophagus, your lungs, your ribs, and then the muscles between your ribs, all of those can also cause pain. I'll add another thing that causes chest pain, frankly, is anxiety. And so there are obviously, mental health reasons for having chest pain as well. So it's very important to take a holistic look at the chest and to say, okay, well, do we have a reasonable suspicion that this is heart-related chest pain? And if so, it's totally appropriate to do a stress test. But if you have somebody who, has had a history of heartburn, they know they get heartburn when they eat spicy food, and if they, have too many beers and then, have coffee the next morning, and guess what? That's what they did, and they have chest pain. Well, then, the physician needs to use their clinical judgment to say, well, it's probably your heartburn that's causing your chest pain and not the stress test. So again, it's important to holistically look at chest pain. Who are the best physicians for holistically looking at your body? Well, again, it's a primary care physician. And of course, I'm biased here in favor of primary care physicians because, well, as an internist, I am one. It's also the way that the majority of people access health care outside of this country. So in places like Great Britain, they all use primary care physicians extensively before they see specialists. So, at a basic level, part of the reason you don't want to get a stress test is because they actually use nuclear radiation to perform it. So if you need it, great, but if you don't need it, it would be good to avoid that nuclear radiation if possible. Okay, overutilization number 7 are full body skin exams. Okay, these are typically performed by dermatologists. and it's used to screen for skin cancer, typically for melanoma, but also for basal cell and squamous cell carcinoma, which are the other two forms of skin cancer. The important thing here is not all cancer screening tests work. And so the U.S. Preventive Services Task Force actually, they looked at all the data in regards to full-body skin exams, and they actually found that full-body skin exams, there was no evidence to support that they actually prevented skin cancer or caught it any earlier. So just unfortunately, we just don't have a good screening mechanism for melanoma or basal cell carcinoma or squamous cell carcinoma. And so there are some employer prevention plans that might actually include full-body skin exams as part of prevention, but just know that the USPSTF, which is sort of the gold standard in terms of, what preventive services have enough evidence to support them, full-body skin exams do not fall into that category. And so if, because of just your own personal interest or because your dermatologist recommends it or your PCP refers to you for a full-body skin exam, just know that they might be looking for a particular abnormal mole, which is fine. I mean, that is a medical clinical indication as an abnormal mole, right? But if you're just like, I'm normal, I don't have any abnormal moles, and I just want to get quote-unquote checked out, just know this last bullet here, just be prepared for your insurance not to cover that at 100%, and it would likely then fall to your copay or your deductible or your coinsurance or however your insurance benefit plan is set up. Okay, overutilization source number 8, executive physicals. So at Johns Hopkins, we used to see these things all the time. These are intensive screenings where people will just get full-body CT scans. They, hey, scan me from head to toe, make sure that there's nothing in there that I'm not aware of. And this is done in asymptomatic people. I just want to go in because I'm an executive and I want to make sure that I'm around for a long time. I just want you to scan me. Another part, oftentimes, of executive physicals are PSA screens for prostate cancer, which are actually no longer recommended by the USPSTF. And a PSA test is a blood test. And so it's unclear if PSA tests actually should be included in employer prevention programs as well, because they are no longer included in the recommendations from the USPSTF. Now, that's an asymptomatic people. If a man is having difficulty urinating or pain with urinating or feels or even having trouble moving their bowels or feel as though they have a mass in their pelvis, then certainly those are all very good reasons to be examined, potentially have a PSA check, and then digital rectal exam is the other thing to check for an enlarged prostate. And so that might be completely appropriate, but again, this is for somebody who is completely asymptomatic. And the reason that you don't want to do it is because the PSA might be artificially elevated, which is called a false positive. It's elevated, but you really don't have prostate cancer. And the problem with an elevated PSA means, okay, now they're going to go in and they're going to biopsy the prostate. And that biopsy, 1, can be bloody, 2, it can lead to complications like impotence, and then 3, if they find a very low-grade prostate cancer, a lot of those prostate cancers are so slow-growing that it could take literally 20, 30, 40, 50 years for it to become symptomatic. And so people will get treatment for prostate cancer, like surgery or radiation, that again might not be necessary, and again leads to problems with lack of bladder control or impotence. So I mean, there are certainly cases where and it's called watchful waiting. You essentially watch the PSA numbers over time, and if they start to accelerate or you start to have an exam that shows a growing prostate, then certainly intervention is completely appropriate. But again, you got to use a measure of caution, and there are times to be aggressive and times not to be. And certainly with PSAs in asymptomatic people, it's not necessarily appropriate to have done. Likewise, for those full-body CT scans, they can find false positives. There was a woman at Hopkins who had a small little nodule on her lungs that they found. They're like, oh my goodness, is it lung cancer? They went in and they operated, and it was just a scar that was left over, probably from a lung infection when she was a kid. Oftentimes, especially people in the Midwest, will have completely asymptomatic lung infections with actually a local fungus. And so it's very hard if you live in the Midwest to say, okay, well, if we do the scan, is that just kind of a leftover fungal infection that the person didn't even know they had, or is it lung cancer? And so if you go looking for these things, the only way to identify that is to then go and do a biopsy and do surgery on the lungs. And as you can imagine, because you've got a rib cage there, a lung biopsy is no minor process. It's a very major process. which can have complications of its own. This woman ended up going to the ICU. Fortunately, she recovered and she was fine, but it was completely unnecessary for her to go through all that. I will then add that CT scans themselves use radiation. They are not harmless in and of themselves. There are 80 million CT scans performed every year, and it's estimated a third of them are unnecessary. There is so much radiation to people because of CT scans that it's estimated that 2% of all future cancers are because of radiation from CT scans, meaning that there are 29,000 cases and 15,000 deaths from unnecessary CT scans. So the American College of Radiology is coming out with much stricter guidelines in regards to when CT scans should be performed. So the point is, if you need a CT scan, so the way that you diagnose, let's say, kidney stones or appendicitis, shoot, it's with a CT scan. So if you are in a situation where you need to have it done, certainly have it done. However, in cases like executive physicals and asymptomatic people, it's really not necessarily a smart thing to do. Okay, overutilization source number 9, ER visits. So it's estimated that 70% of ER visits are unnecessary. This was based on a study of 6.5 million ER visits for commercially insured patients. They also found that the top 3 reasons for ER visits were respiratory and chest symptoms, abdominal symptoms, and then just what they referred to as general symptoms. Okay, so the catch with ER visits is that, you know, the layperson might have a certain symptom, whether it be a cough or chest pain or, you know, nausea, vomiting, diarrhea, what have you. And, you know, shoot, the layperson doesn't know if it's an emergency or not. I mean, that's completely understandable. In those cases, you might need to see a physician, but how could you see a physician and not have to go to the ER? Well, the answer is 1, have a primary care physician. 1, if you have an established relationship with a primary care physician, you're going to most likely be able to get a same-day or a next-day appointment. Or 2, you're going to be able to talk to them or their nurse over the phone, and they might be able to triage you over the phone to see if they need to have you come in, tell you to go to the ER, but at least that way you have a connection with, or you know, in the case of a lot of people with like bladder infections, they might just call you in a prescription for the bladder infection just based upon your conversation over the phone, and you're done. You can go pick it up at the pharmacy and you're done. But again, they're only going to do that if you're an established patient. If you're just some random person calling in, they're not going to do that for you. The alternative as well to an ER, I mean, let's say it's the middle of the night, your physician doesn't have an after-hours call service, and maybe you do need to go to an urgent care center, but again, that tends to be much more cost-effective than actually going to an ER. Worst-case scenario, if you do have something very severe in an urgent care center, they can always direct admit you to a hospital. When I worked as a hospitalist, I would have urgent care centers call me and say, hey, this person is coming in, you know, looks like they have a severe, you know, intestinal infection, and, you know, they would direct admit them to the hospital. So you still you can get the escalated care necessary at an urgent care center, but going there as opposed to the ER might just be more cost effective for you. And shoot, at the end of the day, you might just have a shorter wait as well. Okay, so overutilization source number 10 is specialist referrals. So it's estimated that almost 8%, 7.8% of referrals are completely inappropriate. And almost or over a quarter, 26.2%, are potentially inappropriate. And so a referral is when you go see one doctor and they recommend you to go to see another doctor. So one might be an example of a PCP to a specialist, but then there are oftentimes referrals from specialist to specialist. So somebody goes in to an ENT because they think that they are having sinus problems and sinus headaches. ENT says, let's do some tests and look, use a nasopharyngoscope to look up in your nose. No, it's not related to your sinuses. And what do? They refer you to a neurologist, okay? So maybe a neurologist was not the next best place to go for your headaches or your congestion. Maybe a PCP would have been the right place for it. But literally 54%, almost over half of all patient visits to specialists come from referrals by other doctors. And it's estimated that wasted copays and lost wages from inappropriate referrals total was $2 billion, $1.9 billion a year. And so the point is that if you're referred to another physician, that is not the end-all, be-all. To a certain extent, you want to take that with a grain of salt, and similar to the MRI example, you should ask your physician, look, is this referral really necessary? Or if it's a referral to a specialist by another specialist, you say, well, could I see my PCP for this? And they might, and listen, if they are a good doctor, they're not going to be offended by an honest dialogue in exchange with you. If you have a physician that gets all bent out of shape when you actually try to have a conversation with them, then they probably aren't the right doc for you to see. But it is very appropriate for you to ask them that, and they might say, no, look, for XYZ reason, it still is necessary for you to go to a subspecialist. Totally fine. But if, they might say, well, going back to your PCP, if that's what you want to do, that might be completely appropriate as well. So I think, all you want to do is you want to kind of pause and have the physician pause and say, okay, is this really the right thing to do? And then, if necessary, maybe even get a second or third opinion around that as well. So that brings us to the top 10 sources of overutilization. And now I'm going to talk about a case study where we actually worked with an employer to decrease those sources of overutilization for them. And this is a large 4,000 to 5,000 employee manufacturing company based all over the U.S. They actually have international employees as well. We don't support the international employees. And really, by having their employees interact with their Compass Health Pro to provide them with in-network price transparency and just health system navigation. And look, we were able to interact with almost 80% or 78% of their employees when they were making their healthcare conditions. And look what that did in terms of their PCP utilization. Now, this employer specifically incentivized their employees to use their Compass Health Pro to get plugged in to a primary care physician, and by doing so, they increased it by over 30 percentage points, 31 percentage points, from 49% to 80%. And not only did that use of PCPs decrease overutilization, but it also increased utilization of services that were being underutilized. So what services were being underutilized? Prevention services were being underutilized. And so as a result of, in this employer, they caught a thyroid cancer early, and, the employee was literally so thankful to her employer and her HR department for this program, because it might literally have saved her life. And so not only do you decrease overutilization, increase underutilization in certain areas, but then it translates into, look at this, much lower overall PEPM costs. So really the take-homes are, so here are the 10 to summarize sources of overutilization. 1, antibiotics. 2, imaging. 3, spine surgery. 4, knee surgery. 5, GI endoscopies. 6, heart stress tests. 7, full body skin exams. 8, executive physicals. 9, ER visits. And 10, specialist referrals. And so again, as in that case study, we use our Compass Health Pros by phone or by email, plus our technology to provide health system navigation, concierge, healthcare service, support services for our members, plugging them into primary care physicians, steering them to high-quality, cost-effective doctors and hospitals, really acting as that central hub for all the different employee benefits programs, whether it's vision, a wellness program, dental, they might have a specialty pharmacy support service as well. So really to be able to connect in all of those benefits through the Compass Health Pro and then be able to translate that and plug employees into those various programs has just been hugely successful for folks. And so with that, I want to end our webinar for today. I want to thank you so much for your attention and for attending this webinar. If you'd like to learn more about Compass, please feel free to email me there at ericb@compassphs.com. If you go to our website, you can see there at the bottom, we also have previous webinars that you can also view as well. And you can also, of course, follow Compass on our blog and at my Twitter handle, Dr. Eric B. And so with that, I hope you just have a fantastic rest of your day and rest of your week.